Good afternoon. Welcome to our 10th Seng Distinguished Lecture Series. My name is Gia and I'll be your MC today. Thank you for taking the time to join us online. Without further ado, I would like to pass the time to Emeritus Professor Kwa Ee-Hyok to give the opening address. Prof. Kwa, please.
Thank you very much, Gia. A very good afternoon to all of you. It's a beautiful afternoon here in Singapore after the morning rain. And the participants are not only people from Singapore and Asia, a few from Australia, Europe, even from America. We're very glad to have all of you to join us. This is the 10th Tao Tien Seng Distinguished Lecture. In the past, let me say something about the Tao Tien Seng Lecture. It is from a generous donation from a friend, Mr. Tao Heng Tan, who is the son of the Tao Tien Seng. He was immigrant to Singapore some over 70 years ago, came as a poor immigrant and worked as a waiter in the British Merchant Navy. And he instilled in his children a sense of generosity, compassion, and also empathy. And I'm very glad for Mr. Tan's donation. In the past, the lecturers include Professor Norman Sartorius, the World Health Organization, and also Professor Hong Hai from the business school in National Nanyang Technological University. We also have a historian, Professor Wang Ganggu, and also a musician, Maestro Jeremy Montero, and also a politician, Mr. Abdullah Tamuji. And today we have somebody who is so wonderful, a friend of us, Professor Jeremy Holmes. He has been to Singapore some 23 or 4 years ago to help us in our diploma on psychological therapy. And I'm very glad that he is great to join us. I know it's the small hours of the morning in the UK. He has written many books, and the recent one is called The Spirit of Psychotherapy. We have got a copy of the book with us, and I hope all the trainees in psychiatry and psychology will purchase a copy. So you're ready, Professor Jeremy Holmes? It's all yours now.
Prof. Kwa, thank you very much for your kind words and for inviting me. I'm just going to get share screen organized. And get my slides up. There, right. Well, it's wonderful to be with you virtually, sadly, but it would be even better if it was in real life. And I had such a good time in Singapore all those years ago and formed a very long-lasting connection with Prof. Kwa, and I've always admired his work and loved his novel as well as his novel about listening to a letter from America, as well as his scientific work, especially mental health difficulties with elderly people, which now includes me. And I was saying Prof. Kwa looks 20 years younger than he did when I saw him and worked with him all those years ago. So thank you for inviting me. So standing up for mental health, what do we mean by this? Well, I'm just going to remind you about the prevalence of mental health problems or mental illness. I'm going to use this term, mental illness. And as you can see from that graph or that diagram, you can see that mental illness is absolutely widespread throughout our world. It's integral to our existence as humans, and the brain, just like every other organ in the body, can develop difficulties, malfunction, responds to the environment and adverse environmental experience, and as a result, we see mental illness. Just to take one of the major mental illnesses, depression, as we can see from this slide, very, very common condition. Probably about 1 in 4 of us will experience depression. At least 1 in 10 will experience major depressive disorder at some point in our lives. And An important point to make at this stage, I think, is that psychiatric illness and mental illness are conditions which affect young people and people in middle age, and therefore have a big impact on the workplace and on the economy. And we're finding this in the UK at the moment. I didn't mention to you, I'm living in the UK, I live near London. It's very early in the morning here, it's raining. I'm sure that will confirm any prejudices you have, correct prejudices about the weather in the UK. So there's a big, you might even say, moral panic in the UK, because although the population of the UK, the potentially working population, is increasing, the numbers of people actually in work are decreasing. And this is because of political changes in our country, it's generally known as austerity. There's been a reduction in investment in health generally, but particularly in mental health, and there's a big impact in the workplace. So there's an irony here. Of course, we are really going to be talking about why is it that psychiatric illness, mental illness, is the poor relation in medicine? Why is it that there's no comparable investment in mental illness to the investment we put into cardiac illness or gastrointestinal illness or all the other illnesses which the human frame is subject to? The point I'm making here is that on the whole, physical illness, on the whole, of course, this is a huge generalization, physical illness affects mainly the elderly and doesn't have a big impact in the workplace, whereas psychiatric illness affects young people and has a big impact in the workplace. And therefore, there's a kind of economic argument for investment and attention to and interest in and research in psychiatric disorders. I mean, to take one very simple statistic, the commonest cause of death in men under 50 in the UK is suicide. And I often say one of our major tasks as psychiatrists is to reduce suicide rates. I'll tell you a little anecdote here. When I was working as a general psychiatrist, one of the worst things that can happen to you in a psychiatric ward, one of the worst things that can happen to your team is when there's a suicide on the ward. But this does happen. And we have to remind ourselves that there's a significant mortality to psychiatric illness. Roughly 10% of people suffering from major depressive disorder or bipolar disorder will kill themselves. And the figure is roughly the same in schizophrenia. So these two major psychiatric illnesses, schizophrenia, a major depressive disorder, and bipolar disorder, have a significant mortality. Now, this tragedy happened to me actually only on one occasion in my work in North Devon, where I was a consultant psychiatrist for 35 years. The moment we had a suicide on the ward, the management team descended on our unit. They were interviewing us. There was a kind of culture of blame. And I said to them, when you have a death on your oncology ward, when someone dies of acute leukemia, do you come to the ward in the same way? Do you blame the team, the health team, in the same way that I feel you're blaming us? And I think this little anecdote illustrates the way in which there is a kind of a distancing and othering of psychiatric illness that doesn't apply to what we call physical illnesses. Of course, psychiatric illness is no less physical than other illnesses. It's just that it affects the brain and therefore affects the mind as well as the body. So suicide is a huge issue around the world, and it's one of our jobs as psychiatrists, and one of our jobs, I would say, as health planners, to think about suicide and find ways to reduce suicide rates. So here we are. I don't know if you can see this slide, but the top 3 causes of death in young adults, again, suicide is up there. So the point I'm making is that that psychiatric illness has a major impact because it affects young people. And here's just reinforcing some of the points I'm making. And here was a statistic I was able to find about Singapore. It's interesting that major depressive disorder appears to be much commoner in Australia than in Singapore. And we could have a discussion about why that might be. Now, this is a slogan, which I think is a very good slogan, that was developed by the Royal College of Psychiatrists a few years ago. And I was say, well, actually, I used to develop a slogan which went, no psychiatry without psychotherapy, and try to get the college to adopt that because I'm a psychotherapeutically minded psychiatrist. But anyway, this is our slogan, no health without mental health. And what we see here is the irony, if you like, that although the public feel that spending should increase on psychiatric illness and on mental health, in reality, to repeat the phrase I used, psychiatry is medicines for relation. So if we look at the investment in mental health, both in terms of personnel, research, and even the physical buildings, investment in psychiatry in no way is commensurate with the impact that psychiatry has on the health of the population. And the public know this, but it's nevertheless, nothing much happens about it. Now, I'm going to move, some of you or many of you will be familiar with this research, but it's an incredibly important line of research which was developed about 25 years ago, primarily in the United States. And the important point about this research, which I'm just going to mention, is that it's longitudinal. And the reason I say it's important is because psychiatry can only be understood, mental illness can only be understood, mental health difficulties can only be understood if we adopt a developmental or a longitudinal, or I might even say a historical approach. The child is father of the man, as the British poet William Wordsworth said. In other words, if we want to understand the evolution, the development of psychological difficulties, we have to understand how this person, who might be my age, might be in their 80s, but nevertheless, where they've come from in their developmental history. What are the slings and arrows of outrageous fortune, if I can move from Wordsworth to Shakespeare, that they've had to encounter in their lives. Now, the adverse childhood experience research was able to adopt a longitudinal approach, was able to look at a cohort of people in their childhood and to follow them through into adult life over a 50-year period. And they counted up adverse childhood experience. They counted this up looking at the kinds of things which have an impact on a child's psychological development. Divorce and separation of parents, drug addiction in parents, extreme poverty, physical and sexual abuse. And to cut a very, very long story short, what we find is that adverse childhood experience has a big impact on adult health. Now, it isn't just health, it isn't just mental health, it's mental and physical health. And it's cumulative. That's to say, the number of adverse childhood experience events that you have had as a child, if you have one, it has some impact on your adult life. If you have two, it has more. If you have 4 or 5, it has even more. So this slide, perhaps a rather difficult slide, but it shows the long-term consequences of adverse childhood experience. And I want you to look particularly where it says health conditions. So there's a big impact of adverse childhood experience on one's physical health. So yes, depressive disorder the chances of developing a depressive disorder if you've had adverse childhood experiences is very high, but also lung disease, asthma, kidney disease, stroke, coronary disease. The incidence, the prevalence of all these conditions is increased as a result of adverse childhood experience. So what I'm trying to say from this slide is that our physical and our mental health are intimately linked, intimately entwined. It's what I call the double helix. We cannot really think sensibly about physical illness unless we look and think about psychological illness. And equally, we have to realize that psychological illness often has big impacts on physical health. So here are some principles that I've been trying to put across. So mental and physical health are intimately entwined, what I call the double helix. And now, if we think about ourselves as healthcare professionals, as doctors, nurses, psychologists, and all the other hugely important members of the healthcare team, we like to think of ourselves, or I hope we like to think of ourselves, as operating in the sphere of whole person medicine. So someone may come to us, might be a physiotherapist. We may go to a physiotherapist because we've injured our shoulder playing tennis, to take a sort of trivial example. But that physiotherapist is seeing not just a shoulder, not just someone with a shoulder, they're seeing a whole person. They're seeing someone who has reacted in a particular way to the shoulder injury, that they are, let's say, minimizing the impact. We find that in avoidant attachment, or exaggerating the impact. We find that in anxious attachment. And we have to think about the other joints of their body. We have to think of this person, for instance, may have had a very hard physical life working as a road sweeper or something of that sort. So we have to think about the developmental history of this individual. So mental health is intrinsic to whole person medicine. And I believe the developmental perspective is essential to all medical work. And it's, I believe, in danger. Even in psychiatry now, we tend to simply deal with, if that's the right word, a person's immediate symptoms that they bring to us, rather than thinking, who is this person who has become depressed? How does that depression fit in the whole context of their life, both in their ecology of their life, their relationships, as they spread out in their family, friends, and the environment they live in, their flat, the work they do, the pollution they may be experiencing, both particulate pollution and noise pollution. So those is the immediate ecology, but also the historical ecology. How did they grow up? Prof. Quara mentioned about this, one of the benefactor of this series of talks. That person, he was an immigrant. He worked in the colonial period. How did that impact on his attitude and outlook on life? He had resilience, it's clear, and he passed this resilience on to his children. What is the nature of that resilience? These are all the questions that we as doctors and healthcare professionals need to think about. And I think what psychiatry brings to the doctor-patient relationship is that the fundamental issue of trust. And what's happened in the UK, very sadly, post-COVID, is that the trusting relationship between doctor and patient, particularly between general practitioner and patient, has broken down, or certainly has been compromised. And without that basic trust, then medical care is itself compromised. We need an open channel of communication. This is something that psychiatry brings. That this is one of I brought in Shakespeare and Wordsworth, so I'm bringing all my heroes. Now I'm going to mention Freud, and if you remember, one of Freud's fundamental communications to his patients was, tell me everything that's going on in your mind, however irrelevant or embarrassing it might seem. This is what's known as pre-association. We have to have an open channel of communication with our patients. They have to have a sense that they can trust us with anything, however embarrassing it might be, and that we will not judge them. the long-term viewpoint. So we have to look back into the patient's past. We also need to do our best to look to the future, to think about prognosis. And here I will say something else about psychiatry. It's often said there are kind of prejudices about psychiatry. So the prejudice that we have about psychiatric illness extends to those that try and care for their patients. And there's a prejudice that psychiatric patients don't get better. This is simply not true. The prognosis of even major depressive disorder in modern psychiatry is quite good. And if you suffer from major depressive disorder, you can expect that you'll make certainly a partial recovery, very likely a full recovery. Even with psychotic disorders, the same is true, and certainly with anxiety disorders. So actually the prognosis and the hope in psychiatry is quite high. And part of that prejudice, the irony, is there are many physical illnesses which we all accept quite happily, heart disease, lung disease, joint disease, where full recovery is rare or never to be seen. We don't distance ourselves from these illnesses simply because the prognosis is only partially good. So we need to take a hopeful, long-term viewpoint. And we all the time, as it were, are informed by the ethic which, now I'm going to quote Terence, the Latin author, "Nothing human is alien to me." And that, of course, applies to our work as physical mental health professionals, the human body. There's no part of the human body to which we don't offer respect, but also scientific interest, and the same applies to the mind. So I believe that the psychiatry, as well as being an absolutely vital part of our health system, has a kind of cultural contribution. It stands up for mind-body indissolubility, the developmental perspective. I believe the attachment dynamic underpins all doctor-patient relationships. And we as psychiatrists, as well as understanding the science of mental illness, we also are and need to be experts in relationships and the benefits of relationships. We need to understand how the doctor-patient relationship is in itself a form of therapy. And again, now I'm mentioning my heroes, Michael Barlint, a psychoanalyst whose father was a general practitioner and who introduced the Barlint movement, which is helping general practitioners to be psychologically aware. Michael Barlint used to say, the doctor is a drug. The question is, how much should we prescribe this drug? How frequently and in what dose? Well, I would say the doctor-patient relationship, or I would say the mental health patient relationship, or the health professional-patient relationship. These are all hugely important therapeutic tools that will produce benefit in our patients. And finally, I haven't actually used the word affect or feeling, but the world of psychiatry is the world of feelings, and that's where we operate, that's where our expertise lies, and we need to understand, what do we mean by feeling? What does it mean to feel okay? I always say my aim in life is not to be happy. If I'm happy, I'm very happy, and it's a wonderful bonus. But my aim in life for myself and for my patients is to feel okay, to feel that I've got feelings. Sometimes I'm cheerful, sometimes I'm not so cheerful, sometimes I'm worried. I have children and grandchildren. I can't stop myself worrying about them, but I can regulate, manage, live with, understand the movement of these affects. So why do we need, let's come to our talk, the topic of our talk, why do we need to stand up for mental illness? Well, the very simple answer is prejudice, othering, distancing, the dynamics of fear. We are, for some reason, I think I can begin to understand the reason. For some reason, we are more frightened, or it's possible that we're more frightened of mental illness than we are of other illnesses. We're all frightened of illness. We're frightened of cancer. We're frightened of being unable, frightened of having a stroke, being unable to move about autonomously and independently. But there's an irony in psychiatry, because the organ, as it were, we are frightened, is the very organ of which we are frightened. In other words, the brain. I mentioned the fragmentation of modern medicine, a retreat from holistic and developmental perspectives, and I believe psychiatry is the guardian of that. To give you one more tiny little anecdote, I was once on a train traveling somewhere. I started chatting. As a psychiatrist, I like to chat to people. To my next door neighbor, it turned out she was an ophthalmologist. And it also turned out that a friend of mine had just had quite a serious retinal detachment. And the way one does, even if one's a doctor, the moment you meet a doctor, you tell them all your troubles. So I said, I've had this friend with retinal detachment. What do you think? She said, I know nothing. She was an ophthalmologist, an eye specialist. I know nothing about retinal detachment. All I know about is the eyelid. So she was the world expert on the eyelid. So we have a fragmentation of modern medicine. I believe psychiatry, one of its jobs is to reduce that fragmentation and to think about whole person medicine. So let's move on to the next slide. So what we have here is othering. Psychiatry is seen as something alien. Now we all do this. This is a normal human psychological phenomenon. When we're frightened of something, we project it outwards. We get rid of it. We push it away. In the 19th century in the United Kingdom, we pushed away all the mental illness and all the psychological and social costs and difficulties that go with mental illness. We pushed them all into huge mental hospitals. So every major city in the United Kingdom, I think also in the States, and to some extent, perhaps in your part of the world, was located, as it were, in this other world of the big mental hospital. And one of the great social changes that I've seen in my lifetime, is the closure of the mental hospitals and the movement back of psychiatry and mental illness into the mainstream. So I worked in a district general hospital, and alongside cardiologists, ophthalmologists, dermatologists, etc. And I had my own wards in the district general hospital, but there were alongside all the other wards. So there has been attempts to reduce this othering phenomena. But there's nevertheless massive stigma associated with psychiatry. And here's a slide, perhaps a rather overcomplicated slide, thinking about the kinds of stigma that we have to deal with. We stigmatize ourselves. Our psychiatric patients are ashamed and embarrassed to think that they could be depressed, or that they could have psychotic illnesses, or that they might be developing dementia. And so they distance themselves from services. So engagement is a huge issue in mental health services. It isn't just that the mental health services is the poor relation, that's true, but nevertheless, people with psychological illness, because of the danger of stigma, tend to avoid engagement. And a very important movement in psychiatry started in Australia with Professor McGorry, is early intervention. In other words, if we can get psychological illness, particularly psychosis, early and engage such individuals in treatment, then the prognosis is very much better. And there is this ambivalence in the public towards psychiatric illness. We make jokes about psychiatric illness, we distance ourselves from it, but at the same time, the public knows that this is a danger that will affect them or can affect them or their family, and therefore they do want increased investment. I'm looking at the time. I wanted to make a point here about this issue of prejudice. There are two aspects to us as humans, you might say. On the one hand, we want to appear strong. We want to, especially if we're young people, we want to appear strong vis-a-vis our peer group, both for reasons of sexual reproduction, depends on appearing healthy and strong, but also in terms of work, we need to appear competent and strong. So in a way, it's understandable that we would tend to minimize anything that looks like a sign of, inverted comma, weakness. On the other, so this is a kind of evolutionary attempt at understanding why it is that we have prejudice about psychiatric illness and why we need to stand up for psychiatric illness. So there are good evolutionary reasons, as it were, why we minimize psychiatric illness. At the same time, evolution has endowed us with the attachment dynamic, has endowed us with the capacity to seek help when we are ill, when our function is diminished. Because, as I always say, we have two great assets vis-a-vis our fellow species, and that is our big brain. Then that big brain is one that can malfunction in psychiatric illness, and each other. So if we have any kind of illness or weakness, with the help of our community, of our family, our friends, our secure base, then we can turn that around and regain our strength. So there is a kind of internal battle, if you like, if you're suffering from a psychiatric illness. On the one hand, you want to appear strong. On the other hand, you want to seek out help. And when we say stand up for mental illness, I think in a way we're addressing both of those. We're saying, admitting, facing up to dealing with and overcoming psychiatric illness actually will make you stronger. I'm going to mention Nietzsche. That which doesn't kill you makes you stronger. On the other hand, or in parallel with that, we're also saying that the community is here, the human community is here to support you. The attachment dynamic is built into our biology, and we are going to help you, and we are going to help you recover. We're going to help you regain your connections and your links with that community, because one of the features of psychiatry is, and of psychiatric illness, is that when you become psychiatrically ill, you feel, and to some extent are, cut off from your community. And psychological therapy involves rebuilding those links with the community. So I'm saying that our cultural contribution involves holding on to hope, tolerating uncertainty, tolerating not knowing. That's a hugely important part of our work as psychiatrists, is to have open minds, simply to listen to our patients, to learn from our patients, and to be able to live alongside uncertainty, and while at the same time helping as best we can. Facing up to the inescapability of loss, separation, failure, and death. That's something else which we as psychiatrists have, I think, to offer to our medical colleagues, because there's a kind of denial of all that built into medical culture. And I believe we can summarize some of those points under the heading of mentalizing, which is a particular interest of mine and my research interest. And I believe this is a skill every doctor needs, every mental health professional needs. My definition of mentalizing is to see the other from the inside and oneself from the outside, to think about feelings and feel about thinking, to factor in our uncertainty. Mental health professionals generally, what we want when we're patients is a doctor who knows everything. But in fact, what we get is a doctor who knows something, and that something alongside that is the area of uncertainty, and we need to be able to live in that area of uncertainty as well. And mental health professionals generally, if they're moving away from psychiatry, but psychiatry can teach mental health professionals generally self-scrutiny. Why am I prescribing at this particular moment this particular drug to this particular patient? What feelings did this patient evoke in me? Am I being brusque with this patient? Am I being rather irritable with this patient? Am I being over-loving with these patients? These are all the mentalizing skills that mental health professionals can help permeate into medical culture generally. Just to remind you, mental illness is treatable. These are the success rates. Reasons for delay in treatment: lack of knowledge, lack of insurance, stigma, early intervention. Most mood disorders remit. The prognosis of psychotic disorders is far better in India, for instance. This is research done by my colleague Julian Leff, sadly now with us, back in the 80s than it was in South London near the Institute of Psychiatry, where he did his research. There's something about a community culture as opposed to a narrowed down culture, which means that psychotic illness has a much better prognosis. And I mentioned mentalization-based treatment for personality disorder reduces the length of time in hospital, the length of time out of work, the amount of health of psychiatric medication a person takes, etc. I put this in especially for Prof. Kwa because I admire him so much, and I know his speciality is psychiatric illness in the elderly. But we now know how best to protect senior mental health. And I think the important point about this slide is that psychological illness is a psychosocial phenomenon. That's to say, it isn't just a matter of taking the right pills or finding the pill for dementia. It's all these other activities, being active, having good sleep, a good diet, not drinking, etc. I'm nearing the end of my talk now. So what standing up for entails, I would say, is this is a kind of political slide: parity of funding, parity of respect, destigmatization of mental illness and also mental health professionals, whole person medicine, the centrality of the therapeutic relationship, and what I'm calling the mind-body double helix. And that's the end of my talk. Gone on slightly longer than I should have done. Here are a couple of books that I've, or here's my latest book that you might be interested in. So thank you for listening, and I'm really looking forward to hearing what my colleagues have to say. And I hope we're not sharing the screen. And stop sharing there.
Thank you very much, Professor Jeremy Holmes, on your excellent perspective on the stigma of mental illness. I suppose when we are speaking up for mental illness, it's always good to have an ally in the person of Dr. William Wan, who is not only a lawyer, but also a pastor. He is a very versatile person, and we call him the poster boy of active aging. On his 70th birthday, he did 100 push-ups, something which I can't do. Not even the young man in front of me, Mr. Surin, can do it. And we are waiting to listen to what he can tell us about how to be kind. He was the General Secretary of the Kindness Movement of Singapore, how to be kind to our mental patients. Dr. Wan, please. No sound.
Prof. Wan, you're still muted.
There we go. Thank you, Prof. It's a pleasure to be part of your team in this panel always. Thank you, Prof. Holmes. I learned so much from you just listening to your talk. You know, I'm not a professional. I'm probably the only non-professional here, I think, in mental health and health in general. I'm a training. I'm trained as a lawyer, and I'm still doing some of that. But for the last 14 years, I have been involved in promoting kindness nationally. So that's how I am known for and what I'm known for. We can have our slides, please, Maureen Rose. There you go. I have friends who are struggling with mental illness, as the good professor described it. And I just wasn't sure how to name that. So I just said, I'm struggling. Be kind, I'm struggling. So I'm now speaking up for mental illness as a friend, as a member of the public, as someone who promotes kindness. Next slide, please. I think of the word empathy, and I think the prof mentioned that a few times. Empathy is a big word. I think empathy is most relevant when we are thinking about how we relate with people, friends, and others with such a challenge in their life. Empathy, by definition, is the ability to understand and to share the feelings of another person. I can't imagine a world without empathy. Empathy is such a big piece in the whole world of kindness. How do we understand kindness without empathy? I have defined in some of my writings that kindness is other centeredness, looking out for others. That's being kind. And empathy is the ability to understand others and share the feelings of other person. Next slide, I'm going to make empathy the key word and use this as some kind of a acronym. So we start with E. When friends come to me and or other friends introduce other friends to me, saying that they would like to see a pastor, they like to see me as a friend, and I realize I'm not trained in professionally in deep therapy. Perhaps I can understand, I can listen, I can empathize. Sometimes I can say a word or two. But when you come to professional therapy, I am not trained to do that. Although my son is a psychiatrist, but that's my son. So what do? I encourage, that's the first thing. I encourage professional therapy. I can encourage them to seek professional help. Of course, it's more easily said than done. People who are struggling may not wish to seek help and therapy because of the stigmatization. So I like to tell them that you are going to see someone who can help you as I would see someone in the medical field who would help me, because whatever we're struggling with, it is something we can't do it ourselves. We need help. I don't see mental illness any different from physical illness. It is a illness. And just as I am always, if I have the opportunity, I talk about my medical condition voluntarily, because I want to encourage people to know that whatever condition we have, we can still be positive and we can overcome them by the positive spirit that we have and the trust we have in people who are going to help us. So I do live with a condition, medically speaking, and many of us do live with conditions. I know of someone living with dementia, and she's very, very happy to talk about dementia. She's getting help and she's living a full life with dementia. So I say to my friends who have a challenge or struggling, go get help and live your life fully. Second thing is to mind your language. I think there was a slide that the Professor Holmes showed just now about the language people use to describe or the fear that people have. Oh, if I go see a psychiatrist, I will be labeled mad. I'll be labeled uh, mentally ill, or whatever the case may be. And these are not very nice words to use about people. For the longest time, I grew up calling the IMH, our IMH, Woodbridge Hospital, and in Chinese it's called Xiaogeng, the place for the mad. It's not very helpful. Today IMH is named differently. It's just like a hospital. So the way we use language on people would also frame how we look at people. So be very careful about how we use language to describe friends who are struggling. We should object to some of the language used. Thirdly, the P in empathy stands for patience. As I grow older, as my wife grows older, we realize that we are changing in the way we think, in the way we say things, in the way we remember things. It takes a bit of time to recall. And even names, it takes a bit of time to churn it up. It's there somewhere in our brains, but it's a bit slower now. So everything is slower. Now I can imagine someone with a mental condition struggling with depression and some of these other issues. I think we need to learn patience. If we care, we must give them the time of the day, patiently listening to them, not judging them, sometimes not even interrupting them, letting them have their day speaking to us, have their time. Patience is so important. Patience reflect how much we care. People talk about time is money, and very often people don't have time for one another. I'm a very busy person, but I do try always to find time when people need them. Because when they need us at that particular time, if we don't give it to them, it may be too late. I remember a friend that I was supposed to meet, and because I was traveling, I didn't get to meet. And when I came back, that friend was no more. You see, sometimes it's the opportune time. We must seize the moment and be patient. We move on to the next four letters. Uh, the A is for advocating for their well-being. That's what I mean by speaking up for them and speaking up against those who would not respect them by either the use of the words they choose or prejudice or whatever. So this is advocating. I am also known as an advocate and solicitor in the Singapore legal system. We are always advocating for someone, advocating for a client, championing the cause, so to speak. Yes, we need more of us to champion the cause of those who cannot champion for themselves, of those who feel like, I saw this picture just now on the slide by our professor where this fingers pointing, blame game. And then this person in a huddle, like a fetus. Yeah, that's a fantastic picture of how sad and lonely many of our friends feel. They don't seem to be able to think that they have friends surrounding them. Let's be one of them, surround them, advocate for them, and speak for them. Then teach yourself about mental health issues. I think those of you who attend this particular webinar will agree with me that our first speaker has already done so much to educate us. And there are other professionals following me. We all can learn together. We can read about it. We can learn to understand what's happening to our friends. The more we understand, the better we can speak up for them. Then let's not be NATO. No action, talk only, as we say in Singapore. Let's hold out our helping hands, offer them help. Sometimes it's just a listening ear. Sometimes it's getting into your car and going buy something for them and whatever they need. And sometimes it's taking them to see a therapist. Be practical in offering our helping hands. And finally, the Y stands for yell. Yell. We say, don't yell at me. Well, I want to shout. Yes, I want to yell against stigmatization. Stigmatization is a terrible thing. I worked for many years as a volunteer as chairman of Prison Fellowship Singapore. We have another area where prisoners and ex-offenders and their families and their children have been treated in such a prejudicial manner, such unkind manner, just because they have committed an offense. And they all feel stigmatized. It's a terrible thing. Let's fight against stigmatization. Let's say to our friends and the public, it's okay to have an illness. You have an illness. Surely you have an illness. I have an illness. Our friend who may be mentally ill simply has an illness. So what is so different from us? Nothing. We all need to help one another. And the final slide, please. I helped a a project called Tapestry Project, which is now run by my friend Nicole, who is doing a good job. Nicole is a person in recovery, went through depression as a young woman, saw some terrible things, how people in depression were treated. And as she's in the recovery, she started this organization, and I was her first chairman. It's an organization to weave communities together for better mental well-being through the power of personal storytelling. So she trains people in journaling. Through journaling and sharing their personal stories, they learn to humanize mental health conversation. You can learn a lot about this issue and how to tell stories and how to help our friends tell stories by going to this website. So with that, I thank you for listening.
Thank you, Dr. Wan. That's a wonderful talk. If you go to London, you will see, you'll sit on a train and there's a station called Elephant and Castle. The railway from, the train from Elephant and Castle goes east to the Maudsley Hospital or the Institute of Psychiatry. And sometimes at the station, you'll see some patients with a shuffling gait. These are patients probably with schizophrenia. And whenever we board a train, people will give them a seat to sit down. So I wonder, Dr. Wan, whether in Singapore, are we kind enough? The purple line from Vivo City to Punggol passes through Buangkok Green, which is where the Institute of Mental Health is. Should we say something to them? There's a sign about giving seat to elderly, giving seat to people who are pregnant. Should people also be kind to people with mental illness and to give them the seat? Something for you to think about. I know yesterday, the train from east to west was a breakdown. This morning, Maureen was so late, but it's okay. But I wonder when they get out of the train, do they help the people with mental health problems to get them to the bus? All right. And so the railway to Punggol also passes through Sengkang, which is where Professor Iris Rother works. And I hope Iris will also pass a message to everyone. Professor Iris Rother is one of our best trainees here in the National University Hospital. She's now the head of psychiatry at this hospital called Sengkang General Hospital. She's done a lot of research work on aging. In fact, both of us have a chapter in a book edited by Professor Norman Sartorius on dementia care, published by Oxford University Press. So Iris works in the general hospital, and we find that sometimes the hospital, there's a lot of areas of stigmatization that sometimes can be very upsetting. So Iris, are you ready now?
Yes. Thank you, Prof, for the kind invitation to speak and share at this important forum. And in preparing for this talk, it's really refreshed a lot of my memories of your good teachings about mental health and stigma. I've thoroughly enjoyed my two earlier speaker segments, and I'm not sure that I'm going to be able to add so much more after the two outstanding speakers. But I think where I will come in will be about my experience as a psychiatrist in a general hospital and adding on to the perspectives. I really enjoyed what Professor Holmes has said about how mental health is intrinsic to whole person medicine, and that's actually extremely critical in a general hospital. But before we start proper, I'd just like all of you to have a look at these two photos and have a think about whether you or others amongst you have ever seen one as more of a patient than another, and think about the prejudices involved. Or between these two photos, have we ever valued one particular treatment modality over another, or ever thought that one was not even a treatment? And so with that, I'd like to share this poem with you. It was cited in the Lancet Commission's paper on ending stigma and discrimination in mental health. And it's a wonderful poem by someone with a lived experience of mental health condition. It's titled It's All in the Head by Nikki Chandam. So take a couple of moments to read through it. It is a very powerful portrayal of a lived experience. So I will just highlight the last few segments. So Nikki has said, but all they see are perfectly working limbs. The able ones don't seem to care. The government doesn't listen. The healthcare system is overworked and the loved ones are exhausted. Only those who live with it know. So this is really very powerful. It shows you that while it is invisible to most, there is certainly a struggle. And this adds on to Dr. Wan's earlier presentation and call for us to take action, to be kind. A little kindness goes an incredibly long way, especially for our collective mental health. So what about in the general hospital? In a consultation liaison psychiatry unit, there is a big focus on the interface between physical illness and mental health, as Prof. Holmes had alluded to earlier. And so some of the common conditions that we encounter, and this is not an exhaustive list, would be things like diabetes, chronic cardiovascular disease, lung disease, cancer, neurological conditions like stroke, epilepsy, and chronic pain. And how does this translate to mental health manifestations, symptoms, or conditions? Well, firstly, sometimes the physical illness itself can affect the way the brain works, leading to changes in mood and behavior. So a good example would be something like hypothyroidism, which can affect the mood and cause depression. Secondly, the treatment itself. So some treatments for the conditions can precipitate mood changes and psychotic symptoms. A good example would be steroid treatment that can also precipitate some of these changes. And finally, all of us know that illness can be very stressful and can affect mental health. It affects us in many domains, and particularly for illnesses that are serious and life-changing, you can just imagine the stress involved. So in some studies, it's found that over 1/3 of inpatients in general hospitals have a mental health condition. And some of the more common ones include major depression, generalized anxiety disorder, dementia, delirium, and panic disorder, some of the things that Prof. Holmes has also alluded to earlier. And why is early detection important in this setting? It is actually critical to detect these conditions because it complicates the delivery of medical care. It is associated with much poorer patient outcomes, longer hospital stays, increased rates of readmission, and higher healthcare costs. And as all the earlier speakers have alluded to, stigma is very isolating. It prevents people from seeking help. And in a general hospital setting, when treatments are available and it can impact both the physical and the mental health, ensuring that those treatments are available, that they are accessed, are critical to the recovery outcomes. Unfortunately, we often find that because of the stigma, help is not accessed, or sometimes there is diagnostic overshadowing where physical symptoms are misattributed to their mental health conditions, whether underlying mental health conditions or new onset mental health conditions. So that's very troubling. So in an older UK study, this was 2012, where a survey was done of a consultation liaison unit. They looked at the frequency of stigmatization and its impact on patient care. So it is quite troubling that in a multidisciplinary respondent survey, over 3/4 of professionals actually experienced that there were stigmatizing attitudes towards mental illness. They also observed that there was an adverse impact on inpatient care, and just slightly over a third, slightly over 1 in 4 experience stigma by association, which is something that we do see even locally. So that was 2012, and come to more recently, 2019, a study done in IMH showed that the staff across multiple job scopes. So there were doctors, there were nurses, there were allied health professionals. Over half of them actually experienced moderate to high levels of associative stigma. And in the moderate stigma category, some of the statements that they had identified with quite strongly were that people react negatively when they know they work in a mental health care setting. People make jokes about me for working in a mental health care setting. Once they know a person works in a mental health care setting, most people will take their opinions less seriously, and mental health work is dangerous. And so this is fairly recent. And despite some of the efforts that we have put in, this shows that it is still happening and there's still some way to go in terms of what else we can do. In a New Zealand study of young psychiatry trainees in a consultation liaison general hospital setting, it was a very nice qualitative study with a whole lot of inputs, but I've only extracted a few of them. The reference is there if you're interested in having a look. So these are aligned with the themes that Prof. Holmes had talked about earlier as well. The sense of a lack of prestige, devaluing of the psychiatry trainees. So they feel that they are not the same as cardiology or neurology, and that not enough effort was put in to the referrals to the psychiatry professional. In the second point, it is about the othering, your patients, your specialty. And this happens still fairly frequently. It was not too long ago where I went to review a patient with dementia, with behavioral problems and psychological symptoms of dementia. And the nurses were so frustrated with her behaviors that they said, your patient is crazy. So now this is the kind of language that Dr. Wan was talking about earlier that we do not want in any setting really. And that despite all the education that we give, we're not doing quite enough yet to ensure that we are penetrating across all levels of staff. So then there is also the fact that there is identification, there is a detection of, yes, there are some symptoms, and then medical colleagues would refer patients to us in the general hospital. We would go and try and review the patient, but patient, by their own self-stigma, their prejudices, they don't want to see psychiatry. So they prioritize the physical health over the mental health, and they want to focus on dealing with the physical illness first. And that doesn't really help, because as we know, and as Prof has also very strongly emphasized, they are both very, very interlinked and they impact each other's outcomes. So, and the final point is something that just, it was captured in this qualitative survey, but even as recent as this morning when I was rounding on my patients, my junior doctors were also sharing a similar sentiment. So there's a kind of assumption among the non-psychiatric medical services that we don't do much. We just have a chat and that's it. But as you heard from Prof. Holmes earlier, that chat is full of richness, the developmental perspective, the empathy, the doctor-patient relationship. There is so much in that chat that is therapy in itself. So how can we help? I mean, it's no use just complaining. It's also about what else we can do about it. So in this nice figure from the Lancet Commission's article, they identified key hallmarks of stigma reduction programs. So there are a ton of balloons here, with bigger balloons indicating more important components and activities. But what I think is most important in the general hospital setting and what we can do more, and I'm actually quite energized to do some in this aspect after this talk as well, is in the areas of service integration. So having anti-stigma programs that are built into training for service provision, and this must happen at very early stages across all levels of healthcare providers and social care sectors. And as early as possible, this must be done on a more repetitive basis. Involvement of persons with lived experience. So while we have some efforts in this area, I think in the general hospital, we probably have some more work to be done in terms of co-designing, implementing, and evaluating these programs collaboratively. And lastly, while we can do a lot from the ground up, I think in the end, there is also a lot that needs to be done in terms of policy change, in terms of to quote Prof. Holmes, parity of funding and parity of respect for the field. And so parity of funding is something that we do struggle with quite a lot in the general hospital. And it brings us back to the earlier two pictures, isn't it? These are both patients, regardless of how we see them and what is the traditional sick role or our mental models of what illness is. And these are also both proven treatments which can help patients to achieve remission. So with that, I'd like to thank you for your attention.
Thank you very much, Professor Iris Rother. It can sometimes be very demanding working in the general hospital, and I'm glad you're doing very good work in Seng. Our next speaker is Professor Lee Ching, who has prepared his lecture, but unfortunately, there is a United Nations meeting now in Vienna, and he has been asked to represent the Singapore government. So he has flown over to Vienna, but he has made a video of his presentation. So we'll show it now.
Good afternoon. I'm Dr. Lee Ching, a psychiatrist at the Institute of Mental Health. My heartfelt thanks to Professor Kua for inviting me to participate in this webinar. My topic today is media and mental health and mental illness, and how I engaged the media over the years. I graduated from medical school in 1990 and was posted to the Institute of Mental Health in 1994 as a junior medical officer. I obtained the Master of Excellence Psychiatry in 1997 and was board certified as psychiatrist in year 2000. This year, 2024, is my 30th year at the Institute of Mental Health. Let me say something about stigma. The negative stereotypes, the thoughts, the belief that we have towards persons with mental health issues. The three common stereotypes are: they are dangerous, they are incompetent, and they will never recover from their illness. Prejudice are the negative feelings and judgment based on the negative stereotypes. For example, I am afraid of a person with mental health issues because they are all violent. This subsequently leads to discrimination, which are unjust actions based on the negative stereotypes and prejudice. For example, I'm not going to hire a person with mental health issues because they can violate and harm my staff. Who are being stigmatized? Obviously, the patients and their caregivers, the family members. However, mental health professionals are also being stigmatized. Stigma in the media. Media representation of mental illness promote negative stereotypes, in particular the false connection between mental illness and violence. In the newspaper, 40 to 70% of items cite violence. And characters with mental illness on TV are being portrayed as more violent than the usual characters. And this includes cartoons and animations. Such negative media portrayals have a direct impact on persons with mental health issues and their families. There's also a connection between the negative media portrayal of mental illness and the government responses to the mental health issues. Mental health professionals must hence combat negative media portrayal and work with producers and writers about the impact of negative and inaccurate depiction on persons with mental health issues. There must always be accurate and positive messages and stories about mental illness and persons with mental health issues, highlighting stories of successful recovery, emphasizing on resilience and hope. I know the audience today are not all Singaporeans. Let me say something about Singapore. It's a small country with a population of 5.61 million. It's a multiracial society, about 74% Chinese, 13% Malay, 9% Indians, and the rest of 4% others. The main free-to-air TV channels in Singapore are as shown. The Chinese program, Channel A and Channel U. We have the English program, Channel 5, the news program, Channel News Asia, and also the Malay as well as the Tamil program. The main printed papers in Singapore are the Straits Times, the Business Times, the two Chinese papers, the Morning, Zhaobao, and the Evening Singming. We also have the Malay and the Tamil newspaper. IMH Open House 2001. Professor Kua had highlighted in this journal article, Ubis Hospital, British psychiatry in Singapore. He mentioned, unfortunately, Ubis Hospital, like other asylums the world over, has sometimes been perceived by the public as a shameful place. A successful anti-stigma campaign led by Dr. Lee Chen took place in 2001 with a tagline, winning hearts and minds. It was important not just for the patient, but also for the morale of the staff. Fast forward to 2023, I was the speaker, and this auditorium that can seat 200 people was fully occupied on a Sunday. The residents who lived nearby came to support the event. Not only do we do open house, we also work closely with the media by participating in public forums organized by the media. On the left is a public forum on depression. The lady in red is a famous Hong Kong actress, and the gentleman beside her is a famous Hong Kong director. On the right is another public forum held just before the COVID, whereby I spoke about grief and depression. Working with the media essentially is to increase the mental health literacy. Therefore, in our approach to mental health literacy, it is important to talk about self-care, balanced diet, exercise, sleep hygiene, the support from the family members, social connection. These are all important. It's also important to recognize the signs and symptoms of mental health distress and condition. We also need to destigmatize mental health condition so that we can reduce the duration of untreated illness. We need to know how to communicate with one with mental health distress or a known mental health condition. We need to be able to listen, offer a listening ear, and not rush in to give advice. Lastly, it's also important to direct a person with mental health issues to the appropriate resources. For the past 8 years, since 2016, I have a column in the Chinese local paper. Every month, I will contribute an article on mental health issues or a mental health condition. I compiled the articles into 2 books. The first was launched in 2019 at a public forum in conjunction with the Together Against Stigma conference, which was launched by the then President, Madam Halimah Yacob. In fact, we have prominent speakers like Professor Norman Sartorius at the TAS, Together Against Stigma conference. The second book was launched last year. As you can see on the first book, on the cover of the first book, there were 3 persons sitting there, chatting, talking about mental health. 3 years down the road, they are able to climb up the mountain, look at the beautiful sky, the white clouds, the sun, and this instills hope in the readers as well as the person with mental health conditions. I will pause here for a couple of seconds for those of you who are interested to scan the QR code of these books. These books are offered free for the public. As mentioned, the first book was launched at the public forum. There were about 200 readers who turned up, and the second book was launched over the radio station. Working with the media is also to advocate for persons with mental health issues. On the left is an English article on help for the mentally ill to rejoin the community. Similar article in Malay is reflected on the right. Working with the media is also to highlight successful stories. These two books, the one in English and the one in Chinese, are essentially stories about patients with serious mental health conditions like schizophrenia, delusional disorder, bipolar disorder, who have benefited from the psychosocial rehab program and are now able to live independent life within the community or even find a job. Likewise, when I was the program director of the National Addiction Management Service, we also compiled two books in English and also in Chinese to highlight successful stories of persons who have recovered or in the process of recovery from their addiction. It's also important to highlight mental health treatment to the public. They need to have such information so that they can make informed consent and also informed decision on the treatment. Example is this article on schizophrenia, the causes, the treatment, the prognosis, and this helps the patient and the caregiver to decide on the treatment. You may ask, why are these articles in Chinese? As mentioned previously, majority of the Singaporeans are Chinese, and there's still a sizable population of Chinese who are not able to access information in English. This is a recent article on the choice of ADHD drugs. Again, this is a condition that most people may not have a clear understanding. In the past, we think that the kids are playful, mischievous, or naughty, but indeed, this is a psychiatric condition that can be treated with both pharmacological and non-pharmacological treatment. However, it's also important to highlight the side effect of drugs. For example, this is an article in the magazine to talk about the risk of sleeping pills. While they may be able to help a person with sleep disorder, potentially they may be addictive and they may also interact with other drugs and also with their physical conditions. Working with the media is also to introduce hospital services or to highlight some of the prevalent studies or incident studies that we have conducted. For example, the Singapore Mental Health Study. In this article, I was interviewed about the emergency service of IMH so the public get to know what are the conditions we manage and how the person can access help in an acute situation. We cannot just focus on treatment by the hospital. It's important for us to involve the community, especially for those conditions that are mild to moderate. In this article, a Malay article, it highlights the collaboration between IMH and 4 social service agencies, the community services, to manage youth and adolescents with mental health issues. The lady in the traditional Malay attire is none other than our ex-president, Madam Hanma Yaakob. She's a very strong supporter for mental health. I am currently the president of the Singapore Association for Mental Health, SAMH. In May this year, we are privileged to invite the current president of Singapore, Mr. Tharman Shanmugaratnam, to help us to reopen our group home. This is a home in the community that allows patients with mental illness to live independently with minimum support from the SMH staff. Going forward, we know we have to work closely with the new media, and people nowadays tend to be busy. They are not able to spend too much time to read a full article. They are relatively impatient. So to attract the readers, information needs to be bite-sized. This is a recent news about stigma faced by the mental health professional, and I was interviewed together with a nurse working in the Institute of Mental Health. The tagline was quite attractive. You might end up becoming a patient. Mental health care professional share their stigma stories. Always consider partnership when working with the media. 1 + 1 is always more than 2. For example, this is a TV program on stigma of depression that we work closely with the Health Promotion Board. Let me share some tips about working with the media. Always be humble and respectful. In fact, we always be humble and respectful, not only to the media, but to the patient, the caregiver, the community, and our peers. We do know that not all media share our agenda. They are very time conscious, so be timely, be prepared for the interview, and be honest. What do I mean by honest? For example, if you are not able to provide them the statistics or data, you may have to decline the interview. However, when we want to send out a message, let the message be clear, be brief, and succinct. In the end, I believe we can always strike a win-win for both parties. This is a magazine that was published by the Institute of Mental Health. It's on staying away from stigma. I just wish to say something about the code. Labels and stigma related to mental health issues are a huge impediment to a person's recovery. We need to focus on the person instead of his condition. The condition does not define him. Do email me if you have any comments, feedback about this presentation. Lastly, let us continue to speak up for mental health, continue to speak up for mental illness. With that, I thank you.
Well, thank you, Li Cheng. We'll quickly move on to the question. When the flyers were sent out, many questions came on to my computer, and I try to summarize them in quickly. I think time is catching up. And the questions that often asked are psychiatric patients violent? You've heard that from Prof. Holmes already. Is recovery difficult? Are there preventive strategies? Then this burning question is suicide prevention. Is it possible? There is a big study conducted here in Singapore, one of the longest follow-up study of schizophrenia. People thought that schizophrenia had a very poor outcome, but this is a 25 years study conducted by Professor Soy Wing Fu, who was the first prof of psychiatry in the university. And you see that in the initial stage, there are about 160 patients, and after 25 years, the attrition was not very high. They have about 70 patients on the follow-up. In contrast to the American study called Katie study, in which after a year, 66% of them defaulted treatment. So you see that after 25 years, good meaning that they have no symptoms, but they need some medication to prevent any kind of relapse. Fair means they still have symptoms, but on follow-up. And poor means they continue to deteriorate. So you see that even 25 years later, about 23% of them is still doing quite well, and been published in international journal. I was invited to give a lecture at the Royal College meeting in Edinburgh some years ago. Another one is the people mentioned on alcoholism, on drug addiction. People say that very poor outcome. And in the 1970s in England, a paper published by Professor Griff Edwards from the Maudsley Hospital, they found that 50% of people defaulted treatment after a year. But here in Singapore, we did a similar study, and the outcome was slightly better. You find that the blue columns are those who recovered. After a year, about 68% recovered. And this question often asked in a college meeting, and I mentioned that in compared to UK or America, all the patients in Singapore all are look after the family. And the family look after them. If even their relapses, there's so much tolerance. So the burden of care falls heavily on the shoulders of the family. And then someone asked about suicide. Is it possible to possible to prevent suicide and make it less often? And you find that in this study was published in the World's Journal, and it was a study sometime in 1995. In 1994, I was a visiting fellow at NIMH in Washington. And the NIMH wanted to do a global study on suicide in the elderly. And we found that in 1995, the suicide rate of Singapore was 62 per 100,000, which is the second highest in the world. And obviously, the Minister of Health was very worried, and we did many things. And it's always good when in the Ministry of Health, you have somebody who is close, we know. And there was one lady called Dr. Ling Sing Ling, who was very pro into geriatrics. And Dr. Ling helped us in turn to encourage the government to have more day centers for elderly people, and have more scholarship for psychiatrists, also for nurses, for social worker, and the Gerontology Society had many public talks about depression and the stigmatization, and the suicide rate drop, And we were invited by the American Society to give a lecture in Chicago, and you were quite amazed that the first time in the world, the suicide rate can be brought down. But what is worrying is the suicide rate is going up again. Now it's moving up to about 40 now, and it's very worrying now, because in ASEAN countries, we are the highest, nothing to be proud of, And then the people in the ministry asked, is there a prevention program now? So we conducted a prevention program for depression and dementia at the Jurong area on the west side of Singapore. And this is a study done some years ago with Professor Goh Lee Gan. And this study was conducted in a shopping mall earlier on. If you remember, Dr. Holmes mentioned about Professor Patrick McGorry from Melbourne. Patrick McGorry gave me the idea of trying to destigmatize by asking people to come to see you in a shopping mall rather than in a hospital or a clinic. And we're wonderful because the people who own the mall, the Lee Kim Ta family, gave us a space and gave us a donation, and we work on that. We also have lots of data from the memory clinic of the hospital that people with depression and dementia are people linked with hypertension, diabetes, and also we encourage them to exercise and also other activities. Tai Chi, mindfulness, music reminiscence, and art therapy. The paper was published in the Lancet, and then a lot of questions asked, is this a randomized controlled study? So we've done something for RCT, for mindfulness, and this on the brain imaging been done. Also did some studies also on the telomeres that has been published also in the World Journal, and also for choral singing. We did a study on whether choral singing helps in terms of depression and also of dementia. And this is the first study in the world done in which we scanned the brain RCT of the elderly people before, and then they start off 6 months, after a year, and after 2 years. And your friends from Cambridge University and Harvard came to join in this study. And we also did a study on horticultural therapy or gardening, which is also a favorite pastime. I heard of Professor Jeremy Holmes and also Dr. William Wan, and also I'm sure Iris enjoyed gardening. And we did a blood study on the immune system, and the paper was published in Nature. In fact, we were invited to give a talk at an interview at the BBC. And after 5 years study, we found that the depression rate fell from 9 to 4.5, which is tremendous, half, to intervention, a non-drug approach. And the dementia, the government report says that it's 10%, but in this study, it's only 3%. In Singapore today, there are about 1 million people who are 60 years and above. If 60 years and above, if you say it's 10% with dementia, it means that today for people who are 60 years and above, there are about 100,000 people with dementia. But if you do this program, you find that it's only about 30,000. That means you prevent for about 70,000. My good friend from the Nanyang Technological Institute University, Professor Houston Huas, told me you must monetize the figures to impress the authorities. So he's an economist, and he told me that if you can save about 70,000 people, the medical student did a study for us on health expenditure, and for every patient, you have to spend about $12,000 for the whole duration of the illness. So if you can prevent 70,000, you can save about $840 million. That's enormous, But from the study at Jurong, we now extend it to many parts of the island. H12 Everyday program across the island now, and sitting in front of me is Mr. Surin. He has also expanded to another 20. There are more 20. They call it the H12 Club. So we are spreading the gospel in this way, destigmatize in all these talks about depression, about anxiety, about dementia. This is one way. Now, our colleagues in France, in Indonesia, and Malaysia, and China are also doing likewise, trying to extend the program to all these countries. Our friend, Professor Tomiko, said we are all also medical ambassadors. That we are trying to spread the good gospel to other countries in the state of having goodwill rather than having the wars in Ukraine and Iran, in Gaza and all these areas. Better spread goodwill through all these messages. Now, I got this interesting picture that I saw in the Museum of Modern Art in MoMA in New York City. And it's about a painter called Rain Margaret who sees an egg, but he draws a bird flying. This is important for many people who ask me this question. So what if all these talks on mental stigma, will it bear fruit? So we got to think about the long term of what we are doing. It will bear fruit. We have to be patient. Look at this picture. This is the picture of Professor Jeremy Holmes when he came to Singapore 23 years ago. We asked him to plant a tree. I was then the CEO of IMH. And every visitor that comes to the hospital, I've asked them to plant a tree. Yeah. So Professor Holmes, you have a spiritual link to Singapore now. You have planted a tree. It helps to reduce the carbon footprint of the island and also help the greening of Singapore, which is important also for the health of the planet, reduce the climate warming. But you'll see that when Professor Holmes planted a tree, it did not benefit him because he never came back to Singapore, but it benefited all our doctors, our nurses, our patients, because the tree has grown very big now. So this tree has grown, and he has even given shelter to his good friend, Professor Norman Sartorius, who came to Singapore, and then he came under the shade of a tree. It was very hot day. The conference was on stigmatization, and he was very happy. So whatever we have done, you have done, Professor Holmes 23 years ago, it may not benefit you, but it benefited many people in Singapore. Likewise, when our talk today on the stigma may not benefit us today, it may benefit people in the future. And standing beside Professor Norman Sartorius was the new CEO, Dr. Chua, and look at myself down there. 3 years as the CEO of IMH took a toll on the last vestige of my youth. I aged very fast, and you see that beside me is the matron of the hospital. I want you to know that the logo of hospital is very interesting because I was asked to help to design the logo. When I took over the hospital 24 years ago, I wanted to rebrand it no longer as Woodbridge Hospital because it caused so much of prejudice and unhappy feelings. And we were asked to change the logo. So we helped to design the logo. And on the day when it was designing the logo, it was the finals of Wimbledon tennis. And I thought that the colors of Wimbledon was interesting, deep green and purple. So the colors of IMH is the colors of a championship badminton tennis. We have also, all that I talked to you about, the data are all in a book called Speaking About for Mental Illness, which has won an award, an Asian Award for Health Education. And the idea of this book was, in fact, the idea of our former president of Singapore, Mr. S.R. Nathan, who read this book. But before that, he told me that all of you from the university have done something wonderful for the university, publishing in big journals of the world, the Lancet, BMJ, Nature. But he said, very frankly, all of us lay people, we don't read all these scientific journals. Can you put all this research into a simple book for us to read? So this is the outcome of his suggestion. We are also doing something interesting in terms of wondering whether plays or musical can also change people's attitudes towards mental illness. And so we had a musical last year called Unforgotten, based on a novel I wrote called Listening to Letter from America. And another professor in NUS in the university, Dr. Lynette Tan, did a study of students who saw the film before and the outcome after. It changes the attitude towards mental illness and also ageism. And finally, there's something that we want to do all the time, a different platform, about whether whether cinemas and films can also help to change. We know that sometimes they stigmatize mental illness. So there is a well-known film producer in Singapore called Soki, who has got a film that's shown at the Cannes Film Festival in France. And he has read a book I wrote called Undefeated Mind. And he wants to make a film about the prejudice and the stigma of mental illness based on a novel I wrote of the people in Woodbridge Hospital in 1981. When I first came to work, I saw the prevalence of this problem in the country, and the staff and the nurses who work on in the mental hospital despite all this stigma. And we have a very award-winning composer called Professor Chen Zhang-Yi, who has agreed to compose the music for this film. So there are many things that can be done. I've finished now, but there's a lot of questions being sent to me. And one question is, what else can the government do? Maybe I'll ask Professor Holman first. What else can the government do to destigmatize mental illness? If you are asked to become the new health minister of Great Britain, or Britain, is it still Great Britain? What will you do?
Well, I think I'm just rather overwhelmed by these wonderful talks I've been hearing and the amazing work that's been done. It's produced a really interesting feeling inside me, which is not a very political feeling. You asked me a political question. I think I'll just make two very simple points. One is for leading people to own their own mental illness problems. So we had a Prime Minister, Tony Blair, a Labour Prime Minister, and he had a kind of right-hand man. He was the press secretary. He was with Tony Blair all the way, this man has become completely open about his own depression and alcoholism. And that has made a huge impact, I believe. So I think politicians now are much more able to show their psychiatric problems. Going back to my talk, this balance we have to strike between appearing strong on the one hand, but being able to ask for help on the other. And they're now much more open about being able to ask for help. This was Alistair Campbell, it's his name. And the other is just the very simple point of investment, parity of investment. So we want our health minister to say, we are going to put as much research money, as much money into buildings and personnel and in mental health as we do to the other medical specialties. And we think, the talk mentioned monetization, we think this will have a big impact on the economy, because if we can get our mentally ill patients back working, that will improve productivity. So it's a very useful investment, not just for the point of view of kindness. I love to talk about kindness, but it's also useful in this pragmatic way of boosting the economy and making us all materially better off. And that, in turn, should reduce the amount of psychiatric illness, because we know poverty and psychiatric illness go together. But I imagine we're ending this wonderful talk soon, and I just am overwhelmed and delighted and so happy to see that tree. It almost brought tears to my eyes. So I think planting seeds, the most important thing we can do, and to remind ourselves that, as I said in my talk, there's a developmental process, and if we understand that process, that little seed turns into a sapling, and that sapling then turns into a tree which shades you from the sun.
Thank you. Maybe I'll ask Dr. Wan and Professor Iris, anything you encourage the government to do? I know they've now got a committee for mental health, which is something we never thought about 40 years ago. So Dr. William Wan, if you meet the Minister of Health in just one or two lines, what do you think you can tell him about?
Well, I will tell him that the state of a nation is to be measured by the care we give to people who need the help. And these people need help more than we imagine.
Thank you, William. Iris, anything for the Minister of Health?
Prof, I think I'll just add that there is already a lot of work going on, as you've mentioned, with the interagency task force and the national wellbeing strategy. I suppose a little bit of patience. When you plant the seed, it also takes time to grow into a tree. But certainly more money coming our way would be helpful to resource not just research, but about services. And the recognition that there is a difference in mental health care delivery in a mental health care institution versus a general hospital setting, which is something I feel sometimes it's lost in all the conversations. Yeah.
Right. Some years ago, I was invited to give a lecture at Cambridge. And during dinner, we had a professor of economics beside me, and he asked me, what do you think are the factors to account for the economic miracle of Singapore? And I told him it has nothing to do with economics, It has to do with two factors in the human mind, mental resilience and creativity. I hope this will let people know that the mental health and so important for your creativity and for the success of whichever country you're from. I want to close this because time is catching up. We want to thank all of you who participants and I will tune in. I must thank all the speakers. Professor Holmes got up so early in the morning and hope we can continue a cup of tea. Dr. William Wan, Iris, and also our benefactor, Mr. Tao Heng Tan, listening in from his office. But I'm also thankful that there are three ladies in here, Maureen, Jaya, and Yi. They are both the three ladies who helped us in this webinar. It's only about 1.5 hours, but it's taken them 3 months to prepare it. I know it's end of the year, their performance will be evaluated. I hope the authorities will give them an extra bonus. Certainly without them, we cannot carry on this webinar. So thank you once again, and have a nice day, or what is left of a nice day. Thank you.
Big thank you to our speakers today, and the recording of this webinar will be available on our Facebook and YouTube. And if you have yet to visit our Nature and Breeds exhibitions at Maylab Alexander Hospital, it will be open until 28 January 2025. And once again, thank you and have a good afternoon.